On to today's program. I am Laura Dierda with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following the completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they did not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after the completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Lisa Rock is the President of National Medical Billing Services. Joining her is Jessica Edmiston. She is a AHIMA-approved ICD-10-CM trainer and the Senior Vice President, Performance Review for NMBS. Tamara Wagner is the Vice President, Performance Review for NMBS, and Allison Cooley, CPC, is a spine coder for NMBS. It is now my pleasure to turn the floor over to Lisa to begin today's presentation.
Thank you very much, and I appreciate everyone allowing us to share some of the problems that we've discovered over the years and solutions in pain and spine coding. It's a very difficult environment today. We're going to discuss the following issues: anatomy specific to pain and spine, the documentation challenges that we've seen on a regular basis, the challenges of the LCDs and the payer policies and the frequencies and differences of both. A major problem today for spine and pain is medical necessity, and we'll show you what we've seen and how we deal with that. A very short discussion on when and when not to apply NCCI edits. Unusual implants with spine coding, such as bone marrow aspiration. And then we're going to touch a little bit on new technology, ICD-10, and opportunities for revenue in this environment today. And with that, I'm going to turn the floor over to Tamara Wagner, who's going to go through anatomy.
Next slide, please. Beginning off on tough coding issues, we're going to start off with anatomy. This slide is just a photo of various muscles, just parts of the anatomy of the entire body. Next slide, please. The first challenge for pain management coders is knowing the anatomy of the spine and the specific regions, cervical, thoracic, lumbar, and sacral, as well as the code sets used for pain management coding. It's important that the coders know the full anatomy of the spine in order to properly interpret the operative note. You have various information such as approach. For example, you will see words such as interlaminar, caudal, transforaminal, facet joint versus medial branch block. You have to know what those words mean in order to assign not only the appropriate code, but the appropriate level. And also, too, you need to also be familiar with diagnosis assignment. Be sure to choose correct diagnosis codes based on the region. Most of the ICD-9 codes in pain management are specific to spine region. Also make sure that your providers are providing the most specific diagnosis. This even becomes more important as we transition to ICD-10. Next slide, please. This slide is a chart created by Marvel Hammer. It's a very good reference tool, especially for transforaminal and facet joint procedures. For coders that are new to pain management coding and are unfamiliar with the anatomy, this chart will provide a clear picture of the nerves and the joints and the relationship of the structures. Next slide, please. In looking at the anatomy of the spine in the previous chart, you want to really be familiar with not only your facet joints, but the medial branch nerves that innervate those joints. typically two medial branches innervate each facet joint until you get to the L5-S1 facet joint. So for example, if you look at the cervical region, the C3 and C4 medial branch nerves innervate the C3-C4 facet joint. And as you move down the cervical region, there's a presence of a C8 medial branch nerve. And with this C8 medial branch nerve, as you cross into the thoracic region, it moves all of the nerves down one level, as I like to say. So your thoracic and lumbar regions don't match up one-to-one with your nerves and your facet joints. And what I mean by that, for example, if you look at your T11 and T12 medial branch nerves, they do not innervate the T11, T12 facet joint, but rather they innervate the T12, L1 facet joint. So regarding CPT guidelines, if you are having a procedure performed at the T12, L1 facet joint, you're going to choose from the cervical thoracic code set. However, if you move to the T12 and L1 medial branch nerves, those two nerves innervate the L1 to L2 facet joint. And therefore, if you see T12 and L1 medial branch nerves, you're going to choose from the lumbar region. You're going to use the 64493 if it happens to be a lumbar facet joint. And then, of course, we look at the L5-S1 facet joint. That's everybody's favorite. Please be aware of the fact that you have to have your L4 medial branch nerve as well as your L5 dorsal ramus in order to report the L5-S1 facet joint. Some providers believe that there's an S1 communicating branch to the L5-S1 joint. So don't be tempted to code a two-level facet joint or RFA procedure if you see the L4, the L5, and the S1 nerves documented, because that truly is just one level, the L5-S1 facet. Next slide. This slide just includes a picture, a cross-section of a vertebrae showing the spinal cord, the nerve roots, the neuroforamen, and vertebral body, as well as on the right side a picture of the various structures of a spinal nerve. So many times we see these words used in an operative note, and it's just a good visualization of how they look in the spine and in the nerve. Next slide, please. Moving on, our next topic is documentation challenges. Next slide, please. In pain coding, half the battle is obtaining accurate documentation. We see discrepancies all the time between procedure heading and the actual description of the procedure. We see inconsistencies within the operative report. As an example, on the left side of this slide is an example of inconsistency for laterality. You see in the procedure heading, it's a left procedure, and then in the body of the note, you see left and bilateral. So, what do we report here? You need to verify this with your provider, because if it truly is a bilateral procedure and you're reporting it as a left procedure, you will be losing out on revenue. Missing information is another issue that affects revenue. Do your providers provide his documentation in a timely manner? The longer they take to complete their documentation, the longer a claim takes to get paid. MD queries. If you ever have clarifications that are needed in an operative note, we use what's called an MD query. It's a simple form that can be used. It becomes part of the medical record. We make it as simple as possible for the provider to complete. We kind of just use a check-off list where they can quickly check off what they did in the procedure, and then we can just finish the coding and make it part of your medical record and go from there. EHR cloning. With so many EHR with so many EHR systems today, we're finding that a lot of times in pain management, the doctors are cloning the records. And by that, I mean they carry the same document from each visit to each subsequent visit. So you want to make sure that you talk to your providers and make sure they're creating an individual record for each individual record or each individual visit, because carriers will look at that documentation and you know, they'll flag it since they're cloning the record. Also, too, I've had many conversations with providers with their documentation where sometimes they don't even have the anatomy documented accurately for a compliant note. So just be sure that everything in your documentation matches and it is compliant. Next slide, please.
Allison, would you like to, Allison is our senior spine coder, if you'd like to walk us through this slide.
Certainly. On Tamara's topic of obtaining proper documentation, a lot of times in an operative report, we see decompressive surgeries, laminectomies, facetectomies, and foraminotomies. And a lot of times the physician will simply state, I did a lumbar decompression at L4-5. Unfortunately, when they say that, that really only gives you the option to code 63047. Lumbar decompression codes such as these are coded by the nerves specifically that are decompressed, because you're not decompressing bone by removing bone, you're actually decompressing the nerves within the neural foramen coming out. So what we like to see is for the physicians to specifically state what nerves they are decompressing when they do these procedures. For instance, you can remove bone from L4 and L5 and only decompress one nerve. But if they remove the bone, from L4 and L5 and they specifically state that they decompress the two nerves at that level, then we are able to give them 63047 and 63048. So unfortunately, if their documentation isn't adequate and it isn't perfect, it could cost them the additional levels of decompression, being able to bill them in addition. Next slide, please.
Thank you. And then Tamara, you're going to go back to medial branch blocks.
Yes. This slide is an example of proper documentation for a bilateral 3-level lumbar medial branch block. If you read through the example, you'll notice that not only does the provider specify where he's placing the needles, but he's also giving the specific medial nerve that he's targeting and anesthetizing. Once again, I just want to reiterate that coders really need to understand what nerves innervate what joints. And in this example, you can see that the L2 and L3 medial branch nerves innervate the L3 to L4 facet joint. The L3, L4 medial branch nerves innervate the L4, L5 facet joint, and the L4, L5 nerves innervate the L5, S1 joint. So like I said, this is a 3-level bilateral lumbar facet joint procedure. Next slide, please. And this is just another example of proper documentation. In this note, we have a right-sided 2-level cervical medial branch block procedure. And it would be reported with a 64490, 64491 right. And you can see the doctor documents that he's going in at the C5 articular process as well as the C6, C7. And so you have 3 nerves being anesthetized, which equates to 2 facet joint levels. Next slide, please. Moving on to additional tough coding issues, LCDs, NCDs, and payer policies. Next slide, please. It's very important for pain management coding to utilize LCDs and payer policies provided by CMS and insurance carriers. If you use a coding software tool, you can usually access your LCDs within these tools. CMS also has a lookup tool on the internet for finding state-specific policies. These policies are being updated more frequently, especially your LCDs with Medicare. They seem to update them several times within a year. Most of the insurance carriers, the commercial carriers, will update their policies on a yearly review. The policies provide diagnoses that meet medical necessity, specific guidelines such as frequency of injections allowed in a given time frame, limitations, conservative measures, and anything that needs to be documented in your operative notes to meet medical necessity. It used to be at one time that everybody thought medical necessity just meant having a diagnosis that meets the policy, but more and more in pain management, the last few years, they've been under the microscope, and so it's getting tougher to get claims paid by these payers that are asking for full medical records just to see that the proper things are documented as far as frequency of injections, progress of treatment, the amount of pain relief, those types of things, much more than just a diagnosis to meet medical necessity. And then good communication between you and your providers is very important, especially if you have providers that you're seeing a trend where they're not meeting medical necessity. You need to continually educate them and provide them with these updated policies so that they know what they need to include in their documentation so that they're getting their claims paid and paid accurately. Next slide, please. This is just an example. If you look on the left-hand column, we've just listed the diagnosis codes under a CMS Medicare contractor's policy for medial branch block. On the right-hand side, we've included a payor medical policy. We just wanted to show a difference in these policies. Some policies might have several different diagnoses. As you see in the Medicare policy, they're showing 11 diagnoses for a medial branch block, whereas the payor policy on the right-hand side is only showing 6. So it's very important to be familiar with these policies and what codes are included in each policy.
You know what I think is interesting on this slide is 724.5 backache unspecified. It's a payable diagnosis code with some of the larger commercial carriers. However, Medicare will not pay for it. And each payer has their own specific list of approved diagnoses for certain procedures. And this is just one example of the differences. Very difficult to manage today. And of course, if you use the wrong diagnosis or the right one, maybe, it could be an unpaid claim.
Next slide, please. Next slide, please. This slide is just a continuation of the Medicare LCD shown on the previous slide where the asterisk, we give the explanation of the asterisk. It's very specific what to use these specific ICD-9 codes for what diagnoses. So you want to pay attention to any asterisks that are included in your policy. Next slide, please. Next slide, please. The next few slides contain examples of various Medicare contractors along with different pain procedures and the differences in their guidelines and limitations for various procedures. As you can see, even the CMS contractors vary in their policies. So just remember, to pull your specific state LCDs and have them handy as you code. Next slide, please. This slide just shows examples of epidural steroid injections among 3 Medicare contractors. If you read these in more detail, you will see that each carrier has a different policy. How many procedures you can perform in a given time frame. So even Medicare varies in their policies. Next slide, please. I won't spend much time on the next couple slides, but these are just breaking out the different procedures. This one is for the medial branch blocks. And the next slide, please, just gives an example of RFA procedures. Next slide, please. Once again, we've just given an example of trigger point injections with two different CMS Medicare contractors. This is kind of interesting because, as you all know, as coders, trigger points are based on the muscles that you inject. CAHABA gives several different muscle groups. They give an ICD-9 code based on the muscle groups being injected, whereas on slide 24, National Government Services, in their LCD for trigger points, there is only one ICD-9 code that meets medical necessity, and that's the 729.1. I find it very interesting that the Medicare contractors are so different in this respect.
And I know that the contractors change their policies typically once a year, but I've seen the changes as often as 3 or 4 weeks.
Yes, a couple of years ago we had policies changing. It seems like it was every couple of weeks, as Lisa stated. As I said earlier, the insurance carriers seem to do a yearly review, but Medicare seems to change their policies whenever. Next slide, please.
Oh, slide 25.
Slide 25, please.
I know we're kind of flying through this information, but we have a lot to get through.
Okay, moving into medical necessity. Next slide, please. As I stated earlier, payers are requiring documentation to support medical necessity. They're not just, looking at a claim, especially if it's a patient that has come in over and over, because as you know, in pain management, patients are seen over several years' time, and they have various procedures performed over those years. So the carriers are getting more interested in looking at medical records for the patients, for their whole history. So an example of a payer policy, the requirements to support medical necessity, they may list that a patient needs to have 3 to 6 months of conservative treatment, specific percentages of pain relief. Is it greater than or equal to 50% relief if they're given a particular type of injection? Have they had prior physical therapy? Are they on medication therapy? Have they had MRI, and what is the result of the MRIs? Just to name a few of the things that the policies are requiring to support medical necessity.
Well, also, we did challenge a payer that had a contradiction in their medical necessity policy. They said in the same policy that they would approve the procedures being performed, and then in that same policy, a couple of paragraphs later, they said that they consider this particular procedure for any diagnosis experimental. So you have to try to get your hands on those medical policies and read them all the way through, because many times you'll find those contradictions, I think.
Right. Next slide, please. We're going to move into NCCI edits, and I will give the microphone to Lisa.
Okay. This is a hot topic. It always has been in my 32 years of being involved with RevCycle, and it still is today. National Correct Coding Initiatives, or a bundling edit system as it's referred to. Most of the larger carriers are using this or some version of this. McKesson's, I think ClaimCheck is the name of their bundling edit system, is very similar, almost identical to this with a few differences, but most of the payers are using this. You have to check your managed care contracts. I'm seeing a lot of language lately where the carriers are actually putting the edit system they prefer to use in the contract itself, but it's very loose. It's typically language that states NCCI edits or anything else we'd like to include in on that. So you have to be very careful that we apply CCI edits pretty much across the board. There are circumstances where we don't. Some states, workers' compensation, some specific payers. Maybe if you're out of network, you choose not to for non-federal plans. But even when you elect not to apply the edit system, you still have to follow the CPT guidelines. If you're going to use CPT codes, you have to follow the CPT guidelines, and they have their own instances of bundling that must be followed. So if you choose to stay outside of the CCI edits, if you're out of network, for those non-federal plans, you still must follow the the CPT guidelines. So that's sort of the landscape as it is today, but most folks out there are following CCI pretty much across the board because it makes a good argument in the appeals process. But of course, it's up to you. There's no rule that you have to. But you should understand how your carriers are adjudicating your claims. Are they using CCI, or are they using their own sort of made-up version of an edit system, which should always be challenged if it's different than CCI. Okay, next slide. And next slide. I believe, Allison, you have slide 30, spine coating implants.
Yes, I do. Thank you very much. I'm not sure how many are familiar with these auriculotherapy stimulators. There's a few of them now out there on the market, P-Stim being one, NeuroStim being another. They're basically a small electrostimulation device that they attach behind the patient's ear, and the electrodes implant into the edge of the patient's ear. And what they do is they stimulate specific nerve groups in order to control pain for patients. Some people are using them for postoperative pain, and some people are using them for chronic pain. They have other diagnoses that they are used for. A lot of the vendors are suggesting that surgery centers and physicians bill these auriculotherapy stimulators with CPT code 64555, which is for a percutaneous implantation of a neurostimulator for peripheral nerves, along with L8680, which is implantable neurostimulator electrode. However, these particular stimulators are not implanted into the patient. They're actually a topical stimulator that is basically taped behind the ear. And based on documentation and payer policy, only 64999 is used to report these particular stimulators. They do not have a specific CPT code, and they do not meet the guidelines for 64555. There's a lot of vendor pressure and vendor suggestion to use these particular CPT codes because they are payable by many carriers. However, 64999 is not always payable by certain carriers. So they want to be able to choose a code that's able to be paid by the carriers. I caution that only because you want to make sure that you're using the appropriate and correct codes versus coding specifically just for reimbursement.
Well, and also, Allison, if you're coding for reimbursement, you're putting the center or the physician at risk for a take-back later on.
Correct. Next slide, please. Can we have the next slide, please? Thank you. This particular slide is a question that was asked of the AMA in 2013, specifically about the P-Stim procedure. And according to the response from the AMA, 64999 is the CPT code you should be using to report this particular service. They say it is not appropriate to report 64555, percutaneous implantation of neurostimulator electrode, peripheral nerves, as this code is for implanted nerve stimulators only, implanted being directly into the body. This particular procedure, as I said before, does not fit that particular CPT code. Next slide, please. We're going to talk about a few issues with knowing the approaches that your surgeon is making and or the type of technology your surgeon is using during the case in order to appropriately choose the CPT codes. Next slide, please. Knowing the approach that the surgeon is making is important. A lot of the CPT codes in the surgery section are specific to a certain approach. For instance, anterior approach, posterior approach, lateral extracavitary, and presacral. Each one of these approaches has their own section in the CPT, having their own CPT codes associated with that particular approach. For example, lumbar interbody fusion. If you're doing an anterior lumbar interbody fusion, the CPT code would be 22558. Posterior lumbar interbody fusion, if they're doing interbody alone with no posterior or posterior lateral, would be 22630. If they're doing it with a combination posterior or posterior lateral, they would use 22633. Another example of CPT specific for the approach would be instrumentation. Anterior instrumentation would be CPT 22845, where posterior instrumentation would be CPT 22840 for non-segmental and 22842 for segmental. It's very important that you understand the area where your physician is. That goes back to Tamara's discussion about the anatomy, knowing they're not always going to tell you that the patient has been placed prone or supine on the table. So you need to know when he says where he's making his approach, where he actually is in relation to the patient's body so that you can choose from the correct section of the CPT book. Next slide, please. There's a lot of new technologies being advanced. Some of these are different types of how they actually are performing the case. The traditional standard open approach where they make the incision and they go through everything and they get down and they're directly visualizing the patient's anatomy when they're doing the surgery. Minimally invasive can be another form of an open approach. They go in through a small incision and a tubular retractor, and they can still use direct visualization to see the patient's anatomy that they are working on, so that would also be considered an open approach. Then there's endoscopic, where they actually use endoscopy to do the surgery through a small tube with the endoscope, which is indirect visualization. Now, what you really need to know here is exactly what they're doing and how they're doing it, because open approaches and minimally invasive approaches are still covered by all carriers. Endoscopic approaches, however, are still considered not medically necessary by many of the payers. So you want to be sure that you understand what they're doing so that you're coding it appropriately and that you understand your payer policies based on these particular approaches. Next slide, please. There's also been some new instrumentation created. Every year there's new spinal hardware, new implants, and things like that, newer, better, different. The standard for a cervical interbody fusion was a interbody spacer, either made of PEEK under CPT 22851 or made of bone, which would be CPT 20931. And then the surgeon would apply an anterior plate with screws to the front of the vertebral bodies, which spanned the vertebral bodies, and that would be coded as 22845. With new technologies, there's a new thing called a standalone interbody spacer. It's a PEEK interbody spacer with screws all in one. It does not have a separate plate. It does not attach to the outside of the vertebral bodies, and it doesn't span the vertebral bodies. So according to NASS, North American Spine Society, and the AMA and the AAPC have also followed this direction, you would not bill 22845 in addition to 22851 for the standalone interbody spacers. Next slide, please. As I said, knowing what type of implant the physician is using is very important. There are a lot of new implants such as interspinous fusion devices and interspinous decompression devices that are being marketed, and they're being marketed under certain CPT codes, being told by the vendors it's okay to use these particular CPT codes, which would be posterior instrumentation codes. However, these particular devices do not have a CPT code created for them yet. So most of them are considered unlisted by payers. You also want to know the payer policies, because if you're using these particular devices, they may specifically state that these particular devices could be experimental and non-covered. So you definitely want to be aware of the various types of instrumentation, out there, and exactly what your physician is using during the case.
Hey, Allison, how about that? We went back and forth for quite a long period of time on those bone marrow aspirations. Can you talk about that a little bit?
Bone marrow aspiration, a lot of physicians will do a bone marrow aspiration to mix the bone marrow in with allograft or autograft in order to create fusion in a patient. Some of them are using the bone marrow aspirate as a form of PRP in shoulders and knees. There is there's a kit that is used. It's something they use to spin down the bone marrow aspirate before they re-inject it into the patient or mix it in with the allograft.
And it's really expensive. It's very expensive.
It is expensive. On average, the kit is anywhere from $2,500 to $2,900. And unfortunately, the kit itself is not an implant. The only thing in that kit that stays in the patient is the powder that they will mix with the bone marrow aspirate at times in order to create a PRP version. So this is not an implant. It is not billed as an implant. If you wanted your surgery center to try and report it, I would report it under A4649 as a supply.
But that's a tough one. We've gone back and forth, implant supply, because part of it's implanted, most of it's supply, but it's awfully expensive to not get reimbursed. So just something to be aware of. If your carriers are bundling the payments into one CPT code, you might not be aware of the fact that you're not getting payment on those. So, thanks, Allison.
You're welcome. Next slide, please.
Jessica, you want to touch on ICD-10? It still is a hot topic and sore topic to discuss. So I know you probably would rather not discuss it, but why don't you tell us a little bit about what's going on?
Absolutely. With the current outlook of ICD-10 going live on 10/1, we did want to at least mention ICD-10 and what you should be doing to prepare for this transition. Next slide, please. I've included just a small clip of an I-9 to I-10 crosswalk or GEMS mapping. As we know, there's not a direct one-to-one crosswalk from I-9 to I-10, but we do have the GEMS mapping tool, which at least breaks down the code choices that you will have. So if you look at the first example for cervical disc displacement 722.0 without myelopathy, where we had one code choice in I-9, we now have 4 choices in I-10, and the cervical region is actually broken into high cervical region, which would include your C2 to C3 and C3 to C4, mid-cervical, which would include C4 to C5, C5 to C6, and C6 to C7, and then the cervicothoracic region. So you'll want to have that documentation available so you know which code to assign. You don't want to use the unspecified code, so we need to get the doctors trained on providing that information. And we recommend at this time, if you haven't already, to start analyzing the most common used I-9 codes today and crosswalking or GEMS mapping them to I-10 to see where documentation is falling short, so you can provide that feedback prior to 10/1 to your physician. Next slide, please.
Is that all you're going to talk about?
That's it.
Right, because that's a 2-hour presentation all by itself. We understand that. But I think that's really good advice, at least doing the crosswalk in your own surgery center and looking at the landscape right now. I think that's good advice. All right, we're on, I think, Allison, we're back to you on page 39.
Yes, ma'am. We're going to talk about some missed opportunities for coding and some new opportunities for coding for increased revenue. Next slide, please. Autograft and allograft. Now, a lot of people don't bill for autograft and allograft in a spine case because they say that it's bundled. Autograft and allograft is not truly NCCI bundled into the case or the procedures. Medicare deems this particular procedures a zero reimbursement, and they do not pay for them. Some carriers have also taken the stance that because Medicare deems them zero payable, they're not going to pay for them either. However, on the ASC side, many of the ASCs that we deal with, being out of network, we found that they were not reporting autograft and allograft on their cases. I would definitely report the autograft and the allograft because not every payer considers them non-payable or inclusive. And to not report them on any of your cases, you could be losing reimbursement for your center because some carriers do consider these payable codes. So you definitely want to make sure that if there's billable codes in your case, you want to make sure that you're covering those. And these two are with most of the centers that we looked at, missed revenue in some cases because they were not billing them at all.
So it's just a misunderstanding, you think, Allison, in that folks think it's bundled, but it is not bundled. It is zero value, which are two completely different things.
Correct. That's correct. Medicare never said that they were actually bundled. They just say they're non-payable and zero value. They have zero RVUs. So, but as I said, there are some carriers that do take that position just because Medicare did, but there are a lot of payers out there that still pay for these two procedures in addition to your fusions. And
those are expensive too.
The allograft can be, yeah, it can be anywhere from $500 to $2,000 depending on the type of allograft you're using per case. And in some cases like lumbar, you use 2, 3, 4 different sizes of allograft or types of allograft in order to complete the case.
Got it.
Next slide, please. In 2015, Medicare approved a list of spine codes for the ASC payable list. These included cervical spine fusions, anterior cervical spine fusions, a posterior lumbar fusion, and discectomy and decompression procedures for the cervical and lumbar spines. This is a good thing because now you can take your Medicare patients to the ASC for some of these procedures. But I caution on some of these particular procedures, particularly 22551, which is an ACDF, anterior cervical fusion. Medicare only pays a primary code in the ASC. They don't pay add-on codes. So typically when you do an anterior cervical fusion, you're doing 22551, which is the anterior fusion itself, 22851 for insertion of the inner body spacer, and 22845 for the anterior cervical plate and screws. Medicare is only going to cover 22551. They're not going to pay any of the additional CPT codes from this case. They also don't pay for instrumentation in addition to the 22551. This is basically an all-inclusive code. So you need to make the determination as to whether or not it's going to be feasible to be able to do these particular procedures and look at the total reimbursement for this particular case and what the costs associated with that case are, so that you just don't say, well, Medicare allows it, let's go do it. You want to make sure you do your homework first and make sure that you're making sure it's the most feasible way for you to do the procedure in your surgery center, because spinal instrumentation can be very, very costly. Average on a cervical one-level case is probably about $5,000 worth of hardware. And they do not allow additional level either. They don't pay the extra. If you're doing a two-level fusion, they would not pay the 22552. You see 22614 on this list. However, it has a zero payable value. So I'm not sure why they included it, but it has a zero payable value.
Here's the other downside, Allison. for me when I look at all these codes being added by Medicare. For those commercial payers that have plans that pay a % of Medicare as an allowed amount, and I think you all know what I'm talking about, the MRC, the MNRP plans. For spine procedures, we've always been okay in that arena out of network because the reimbursement methodology was usual and customary. Now that there is a Medicare allowed amount, and I'm seeing more and more plans turn over their out of network to this % of Medicare reimbursement methodology, all of these codes are going to fall into that group and off of the UNC for out of network billing. So take a hard look at that piece as you're scheduling cases. And that is the conclusion of our presentation, and I think we're going to open up for questions, right?
Yes, and thank you very much to our presenters for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and will follow up on questions they do not have the opportunity to address. And we do have several questions here, so I'm really excited to get started. The first question we have is, NGS Medicare will not allow paper claims, so how can you give them information on an unlisted claim such as 64999 for PSTEM?
Who would like to take that?
What we do for Medicare claims for an unlisted code is we add a narrative to box 19 of the 1500 form describing what the procedure represents, what that unlisted code represents.
Okay, perfect. And then the next question I have here is, if a doctor stated that he is doing a lumbar interbody fusion, can you assume it is 22630?
Allison, that goes to you.
I was going to say I can take that one. No, you can't assume that it's 22630. They created a new code a few years ago, 22633. When a doctor is doing interbody only, then you can code 22630. When a doctor is doing an interbody lumbar fusion with posterior lateral fusion in combination, there is a combination code 22633 that has to be used to report that now.
Perfect. Next question I have here is, do you know about the reimbursement for the DBM allografts that get added in for spine procedures like DBM putty or strips?
Are they asking about the actual supply, or are they asking how to bill for those?
How to bill or the reimbursement, get the reimbursement for those.
Well, the DBM putty and the DBM strips are all billed under CPT code 20930 as a procedure because they're considered osteopromotive materials, which is covered under that CPT code. As far as billing them out, we do bill the supplies for our centers because it is an implant that stays in the patient. It's used to create the actual fusion. So we do bill for those as an implant under L8699.
And reimbursement would be, that's a tough question. So.
Absolutely. The next question I have here is, can you provide recommendations as to how to handle out-of-network in the ASC? Should the patients be billed the entire portion of the bill, or if discounted, what is the appropriate amount?
Okay, Allison, I think this one goes to me. Heavy sigh here. Okay, technically, you have to balance bill your patients. There's a case, and several, the last one I can think of is in California. A surgery center was waiving out-of-network responsibilities. Cigna sued, and I believe Cigna lost. And that was a win for providers that are trying to practice medicine and create an environment for their patients and not really worry about that piece. However, with that said, technically you are required to balance bill in full. That is the correct answer. What is everyone doing? Everyone's working with their patients and they're trying their best. Now, I will tell you this. January 1st of last year, under healthcare reform, created another write-off category, a legal write-off category for us for those out-of-network balances, and that is a medical indigency. So financial indigency has always been there, and if you follow national poverty guidelines, you can make those adjustments by looking at tax returns and whatnot. But as of last year, we're legally allowed to write off patients that owe balances that would render them financially indigent. So in other words, if paying their coinsurance and deductible would put them in that national poverty guideline or federal poverty guideline, or have them meet those guidelines, then you can write that balance off. So we have those legal ways to write off, and I would suggest that you implement that you have a good collections policy in place, regardless of what it is. But that's a slippery slope. I mean, I know what everyone does, and I know what is required. What is required is to balance bill, except for those exceptions that I just mentioned.
Okay, perfect. Next, all right. Next question I have is regarding trial stim cases, the 63650. If the doctor states he does the first level and then the same procedure at the next subsequential level, are we to assume RT and LT, or can this be done unilateral?
Tamara, you want to take that?
Yes. When they place two trial leads, we don't use RT, LT. What we do is we don't use any modifier on the first 63650. For Medicare, we use a 76 modifier for the second 63650, and for commercial payers, we use a 59 modifier.
Okay, perfect. And then the next question I have is kind of a clarification question. For the unlisted codes used for the interspinous fusion, which unlisted code, or is that correct to use the unlisted code?
Are we talking about the actual interspinous fusion device? If so,
yeah.
22899 was the recommended by the payer policies that I found.
Okay, perfect. The next question I have here is for the CPT 64530, modifier 50 is not accepted. Therefore, bilateral procedure, it should be charged and coded as the 64530 times 1.
What's that question?
Could you repeat the question? Not sure we followed that exactly. Yes.
Sure. Yeah. So for the CPT 64530, the attendee was acknowledging that the modifier 50 is not accepted. So for that bilateral procedure, how would you code that?
Okay, Tamara, you want to take
We would code the 64530 with the 1 unit.
Okay, perfect. Let's see, and then the next question I have here is, what is the expected reimbursement for an ACDF?
Are we talking about the Medicare allowed, the new Medicare allowed for the ACDF? If we're talking about that particular procedure, the national average for that Medicare 22551 is $7,800, but that can vary depending on your locality, as the Medicare rates for the ASC change depending on your location.
Okay, perfect. And can we bill for Coflex under 22840?
Coflex, depending on whether you're using the interspinous fusion device or the decompression device, which is implanted into the spinous process after direct decompression, this is another issue question where manufacturers are saying it's appropriate to use 22840, which is posterior spinous hardware. However, every payor policy I could find that directly addressed Coflex, whether it be the intraspinous fusion device or the decompression device, stated to use the 22899 unlisted code for implantation of those two devices.
Perfect. And the next question I have here, should L8680 be billed on the claim with 63650 on Medicare claims to indicate how many leads were placed?
I'll take that one. No, Medicare considers the 63650 as a device-intensive procedure. Therefore, when they set the reimbursement for the placement of the lead, the 63650, they take into consideration the cost of the supply of the lead. So you do not add the L8680 separately for Medicare.
And just to add to that, if you're placing two leads, you would report the 63650 twice. So they would reimburse you for both of those leads in the procedure codes.
Okay, perfect. And then one last question I have here is the G0260 for the sacroiliac joint the correct coding for ASC when the doctor is coding 27096?
For Medicare and other specific plans, it's based on carrier requirement, but the G0260 is reported on the ASC side, and yes, the 27096 is reported on the physician side, on the professional claim.
Excellent. And I would like to thank our presenters again for their excellent presentation and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.